Hello, everyone. I'm Lissa Myers. I'm your host, and this is Unmute Your Probe, the podcast of the American Academy of Emergency Medicine Emergency Ultrasound Section. On this podcast, we talk about controversy and clinical point-of-care ultrasound. I am your host, and today we're going to be tackling what I think is going to be just a really interesting topic, and that is ultrasound and cardiac arrest. Before we begin, please note, the views expressed in this podcast are those of the participants and do not reflect the official policy or position of the Uniformed Services University, the Department of Defense, or the United States government. I have two fantastic guests today. They were actually on this podcast earlier this year talking about transesophageal ultrasound, but go ahead and introduce yourselves.
My name is Faith Kelly. I am a level 2 echocardiographer, board certified cardiologist, and I work in San Antonio, Texas, and an assistant professor of medicine.
And hello, my name is Dr. Gary Bhagat, and board certified emergency medicine physician, ultrasound fellowship trained, working here at the Medical College of Wisconsin in Milwaukee, Wisconsin.
Great. Thank you both for coming back. Your episode on transesophageal ultrasound was so good that I had to have you guys come back and talk about this really just fantastic topic. I want to start with kind of some open questions. Why do you guys think that ultrasound has become prevalent during cardiac arrest? Because this is a little bit of a controversy. One of the papers we're going to talk about looks at increased length of pulse checks during when ultrasound is used in cardiac arrest, which could be linked with increased mortality. And yet, I can't remember the last code I saw where the ultrasound didn't come out. So why do you guys think this has become incorporated into our resuscitations? And are you going to be talking about any guidelines that either support or don't support the use of ultrasound in cardiac arrest?
I work very heavily with a lot of trainees, both med students all the way up through fellows and other staff. And ultrasound is everywhere. POCUS is in your pocket. The residents come with it. And so I think we have a lot better access to this very convenient technology that can look at multiple organs and very fast and give us real-time feedback. I think it just intuitively makes sense that we're starting to use it in critical care scenarios and during codes, specifically with figuring out if there's types of cardiac arrest, cardiac standstill, reversible causes. With respect to the guidelines, that is I think we're going to talk about that more, but there is not a lot of really clear, yay or nay. I think, Lissa, you sent out a couple papers about different societies have very different views, but we do have some general guidelines. So, yeah.
Yeah, to piggyback off that as well, as far as guidelines go, there's no guideline or society that says, yes, you definitely have to do this in cardiac arrest. This is next in line after your pulse check to make sure you incorporate this into your process as well. And we'll get into the weeds as to why that might be. As far as my training goes, I was already in the era of POCUSes everywhere. So in my training, having ultrasound at the bedside during cardiac arrest was already second nature. And I think part of it is we want to do everything we can. It would be a disservice if we say, okay, we can't defibrillate in this case. We're doing pulse checks, but there's no other intervention we can do right now. Well, let's see if there's other reversible causes for this unwitnessed arrest that we might be missing, and we might be able to potentially save a life here that might otherwise, we might just end up calling it in 5 minutes.
Yeah, I think those reversible causes are one of the reasons that I know I always reach for the ultrasound. And so thanks, guys. With that, I'd like to start with this 2018 study that looked at whether or not POCUS use was associated with longer CPR pauses. I remember I had just finished my ultrasound fellowship when this paper came out, and I remember all of the talk about it at conferences and the Facebook groups, and this was all anyone talked about for about 6 months in my circle, which tells you something about who I hang out with. But this was a 2018 paper. It was a prospective cohort study. It was a single center trial where 24 patients were enrolled over approximately 12 months. And what they did is they looked at video of their resuscitations on these patients that were in cardiac arrest, and they measured the length of the pulse check on video. So there's definitely some pluses and minuses to this paper. 24 patients enrolled into a cardiac arrest study is honestly pretty good. That's a hard patient population to enroll. And I certainly can't fault the method of looking at the video for the pulse checks. It's probably the most reliable way this could be done. But it's a single center trial. And so while they did find increased pulse length with ultrasound, I know that I personally have a little bit of a hard time knowing, is that going to be generalizable, or is that something that was happening at this single center? What did you guys think about this study?
Yeah, it's interesting. So I'll drop these in the chat for other articles too. It's not the first article that's pointed this out as well. There was a 2017 study from, I don't know how to pronounce it, but HUIS, I think Huis et al., that was also similar, small cohort of 23 patients. And they found that with POCUS, it was a 21-second pause, and without, it was still more than 10 seconds. It was 13-second pauses on pulse checks as well. And so they did find a statistically significant difference between with use of POCUS versus no POCUS on pulse checks, which, I mean, at the end of the day, if time on chest is the biggest thing we can do and the most supported thing by evidence for potential ROSC, it could be detrimental to be using POCUS based on these numbers that they're showing. But then once again, these are also, that study and the study, they're also just smaller numbers. So it's really hard to be generalizable based on just the smaller studies.
Yeah.
Makes sense.
There's several studies that have come out in various fields in cardiology that kind of show what we intuitively think. And I know Lissa has a lot of problems with the study. I think it highlighted a couple things and gave us some caution. Obviously, if you do more formal training in point of care ultrasound or an ultrasound, those people were a little faster. That makes sense if you practice. If you are really anchoring on that ultrasound view to guide your resuscitation, as assuming they did in this article because they were probably trying to get good views, and that's what led to the increased time. It goes to the point that it's a tool and not a prognostic or a definite diagnostic tool. So I think I liked it a little bit. I do, and I know it has to have a lot of limitations, but it did. For me, I've actually used it with some of my trainees and saying, yes, you need to practice this. During a code is not the best time to practice getting views. When it really matters, you need to be fast and you need to be efficient and you need to be accurate. And I use this to bring that point home to some of the trainings when I'm teaching them how to quickly get views in the ER.
Yeah, I think that's a really good point. Faith, that was a very diplomatic point given the comments about this paper when we were prepping for this.
Yeah.
No, it's not a bad paper. I think I was a little frustrated when it came out because it felt like all of a sudden, they're like, you're killing people with ultrasound. But I do think the paper is overall well done. And it makes a really valid point. It's hard to track time when you're getting these views. And it would be too easy to elongate the pulse check time. Gary, you looked like you were about to say something.
I just want to make sure, as you had mentioned, this paper came out when you were finishing fellowship. This paper came out when I was starting residency. So it was not, my time was focused on making sure I wasn't killing anyone right away. So I wasn't as familiar with the paper at the time, but I want to make sure was this the same paper I'm looking at, which was that the implementation of the cardiac arrest sonographic assessment, the CASA protocol for patients with cardiac arrest, or did they have a different 2018 Clattenburg paper?
I think there's two papers.
Yeah, this one
The
called on
CASA
point of care
protocol is a
ultrasound.
different article.
Yeah,
Okay,
point of care
okay.
ultrasound used in patients with cardiac arrest is associated with prolonged cardiopulmonary resuscitation.
Okay. Yep. I definitely read and annotated a different paper, but I'll roll with it.
But
I
CASA
mean-
protocol is great, and we're going to talk
Yeah.
about it later anyways, so
Yeah.
that works out well.
Yeah. Which, I mean,
The same, basically.
yeah, actually, it's a little bit different because
Yeah.
if you take their same paper from 2018 that they published, the CASA protocol paper, which in that one they showed that running the code and doing ultrasound with pulse checks did not prolong the pause when they implemented this protocol. So their next paper that actually had a larger N ends up showing that there was, as long as you were focused on your examination, doing everything, you didn't necessarily prolong the pause by comparison.
Yeah, I think one of my takeaways was that you got to have somebody counting for you and that you as the stenographer. Because one of the things that stood out to me is that pulse checks were definitely longer if you had the same person running the code and doing the scan.
Yeah.
Which is, I know in some of these smaller hospitals, I know I've run codes at critical access hospitals where I'm the only doctor. So I'm going to be doing both of these things. And it's hard to time. I don't have a great sense of time when I'm doing these exams. And so I've had to implement, I know one thing that has worked really well for me is I use the Edge 2, the Sonosite Edge 2 a lot when I scan, and it makes it beep when you get to the 6 seconds. So I hit clip and then I scan until I hear the beep and then I take the probe off because I know that the beep means it's been 6 seconds. And so I think there's things that you can do knowing that this is something that we're all prone to.
Yeah. And it's alluded to in the other paper too, but it's one of the things is there's multiple factors going on. It's what view are you trying to get and where are you starting? And ideally, I find that if you already have the probe on the chest somewhere before you pause compressions, that won't cause as much of a delay because that way you're already on the chest, you have an idea of where you're going to be, and then you can start right there. usually for myself, who's ever doing the recording and timekeeping, I hold them to the 10 seconds. So they're looking at the clock 10 seconds, and then we go right back to compressions, regardless of what else is happening. That way we have ongoing time on chest.
Yeah, I think that's definitely a way to do it. I remember reading a paper a few years ago where the authors advocated for use of the apical four chamber, which I think would only work if you were very comfortable doing that exam. Honestly, I can't say I've ever personally tried that. My go-to in cardiac arrest is always the parasternal because I
Yeah.
can get it quickly. I know where it is, and I feel
Mm.
very confident looking for standstill in that particular view.
Yeah. And then the other factors also are your choice of view might be limited based on where are the pads right now and is there a Lucas device going on. So
Mm.
I usually end up going more subxiphoid. That way it doesn't interrupt compressions for me. And that way I'm less worried about gel being in the way of compressions and having to wipe it down as well in between. That way I can just keep the subxiphoid view if possible. So that's usually my preferred go-to. And I don't frequently do parasternal for my arrest. I'll do subxiphoid, and then occasionally I'll try apical 4 if if the body habitus and the other gear on allow for it. I don't do parasternal as much just because that's usually where compressions are happening, where a pad might be as well. I don't want to end up having to muck about with any of that as well, or potentially delay compressions because someone's waiting for me to clean off the chest because I'm doing a parasternal.
Yeah, that's actually interesting because I know in the last paper we're going to discuss it was a Gottlieb article.
I believe, yeah.
Yeah, I tend to go subxiphoid just because of all the things you mentioned, Gary, that I'm actually, because I do a lot of fluid assessment exams, I'm very comfortable and very fast getting the subxiphoid, and also from the logistical standpoints. And our codes tend to be full of people, and so that's usually the place where I can get in. I have a handheld V scan, and so I can just pop in there. But
Mhm.
yeah, they'd actually said that they had, was it better outcomes? Yeah, supported this parasternal long axis over the subxiphoid view. And so that kind of surprised me because that seemed like it would be more difficult in the throes of the code.
Yeah, and some of this is probably just my personal experience of codes, but in the past 10 years, the vast majority of codes I've been involved in were actually traumas. And
Mhm.
so we weren't doing CPR. And so that's probably
Mhm.
skewed my experience pretty significantly.
Yeah.
And I've learned that once you open the left chest, you can't get a subxiphoid anymore. I think it's the air.
Oh,
Yep.
My experience here is probably not particularly helpful in the setting
Yeah.
of a medical code.
yeah, I don't do trauma codes. We do medical codes.
I do both.
We have a good combo here.
Yeah.
Yeah.
All right. With that, I think I'd like to take us into the guidelines. So we've talked about some of the ways that this could be challenging, and you guys referenced some of the ways that it could be helpful, looking for reversible causes. I think we've all referenced cardiac standstill multiple times, which is honestly would be a really great follow-up episode because that is probably a 30-minute conversation in and of itself, the utility of cardiac standstill. But it's something that we're using. And yet, when I went to look for guidelines, prepping for this episode, the guidelines were very hedgy. I don't think I found anything that was particularly definitive. The paper that I sent you guys is by Goody et al. It's diagnostics. It's from 2024. And I'm going to read you guys the ILCOR statement because it sums up this hedginess that I'm referencing. It says, so this is the 2020 consensus statement, and it says POCUS can be performed by experienced personnel without interrupting CPR and may be considered as an additional diagnostic tool when clinical suspicion for reversible cause is present. And then the AHAs also said in 2020 that ultrasound could be considered, but the evidence basis is unclear. That's not very definitive.
Yeah.
Yeah.
I'm familiar with ILCOR. I never actually looked into who all was represented in ILCOR. And I think one difference, I think I would rely more on AHA in this case versus ILCOR, just because looking at like the member organization, it's AHA, it's the Indian Resuscitation Council, it's Resuscitation Councils of South Africa, of Asia. And so there's so many different countries, which also changes the resource availability as well, and the level of training. So I think it's hard to standardize across on a statement for ultrasound when you factor in so many different continents and level of training and exposure to the material. I know even in Italy was working on a different podcast, and in there, focus adaptation isn't as much there for cardiac arrest. So compared to over here, where we're already using it freely, so if the training is going to be different, I think international guidelines may not be there. So I might defer more to AHA guidelines where they have a better scope of what our availability might be nationwide in general and what our training might be. Even then, though, the AHA doesn't necessarily recommend doing it either. I think part of that is when we talked about the first study, these are just small numbers. There's no like other out of hospital cardiac arrest studies. We hem and haw about cooling, no cooling, and we have thousands of patients in those studies. Ultrasound, no ultrasound. These studies are 20, 30, maybe 200 at the most. So we just don't have well-powered enough studies to say whether it's appropriate to do it or not. And I'm a POCUS enthusiast, but I'm also a realist, knowing that time off chest is bad. We probably need better data to justify whether we're doing more harm or good by introducing this extra technology. And we study everything else. We study end tidal, we study use of other devices, Lucas devices, everything else. But there's no high-powered study on the use of ultrasound in the setting of cardiac arrest or not. But also, I think most of us would be afraid of taking away the ultrasound in the cardiac arrest now as well. So it'd be a harder study to conduct because I'd be afraid that we might be causing harm. But maybe we just need a large study to be done to really justify our use of it.
I think going with that, once we do have a technology, as you said, we like to use it. I was digging into kind of the sub-studies they mentioned in this article, and I ran across one that like resonated with me. So it was a retrospective observational study in 2019. And what they did is they took people like me, level 2 board certified echo cardiographers, cardiologists, and this was post resuscitation. So they did people within 60 minutes of ROSC. And why I liked this and what was interesting for me is they looked at, it was about 260 people, looked at each diagnosis. So wall motion abnormalities, were looking about ACS, RV dilation, things like that. And then they actually went on to see how many of those patients actually had the presumed diagnosis. And it was actually quite small. So for ACS, it was about 17 out of the 240 or so had a wall motion abnormality. Only half of those actually got a stent because of it. And these were non-STEMI patients. For RV dilation, it's about 20 had RV dilation. Only 10 of them ended up having a PE on confirmatory study. And so I think what I really took from that was that it is a tool and it's an adjunct. This is a common thing. We can't really use that as the main driver of our clinical decision making. Is a small little piece in time and with the entire clinical picture. And I think if you think about codes, it would be ridiculously difficult to set up a study like this. In the military, we like Alyssa knows this, like downrange and stuff. We have access to ultrasound, but that wasn't always the case. So the first thing I thought of was, what were our rates of resuscitation outside of ultrasound prior to that's use? But I don't know. It'd be very hard to do, and we'll be very hesitant to take that tool away from us, given the potential benefit.
Yeah,
certainly. Although, like y'all have mentioned, there's some downsides as well. Not only the time of chest, but one of the guidelines referenced, and I thought this was an interesting idea, that if someone saw cardiac standstill early on, that it could cause them to stop resuscitative efforts perhaps earlier than they would have otherwise. And so it could become a self-fulfilling prophecy, which I thought was an interesting point. It wasn't one I had previously considered, but it's a valid point, and it's worth considering if you might unconsciously be influenced by ultrasound findings. And if you didn't know that was there, maybe you might try other interventions. And then you can make the opposite argument that you should avoid futile interventions. And you can go around on this all day.
Yeah, but we don't really know. Without like actually looking at cardiac standstill, we don't know how many patients actually have cardiac standstill at some point during their resuscitation. We're doing chest compressions, all that kind of stuff. So we're now able to see things we were not able to see before. And yes, that is going to have an impact on our clinical decision making. But
yeah, and then that's, I know that you alluded to this before. We can have a whole separate conversation on POCUS cardiac standstill, because this was an area of research interest for our fellow this year as well, which was, what is cardiac standstill on ultrasound? And the definitions are varied.
They are. There's no agreed upon definition for cardiac standstill.
And that makes it tricky when they said that there's standstills. What did you actually see? For some people, it's just there's no movement of the ventricles or minimal movement of valvular movement. Some it's no valvular movement as well. So it's really tricky then to say, what is standstill? Is this little flickering of the valve? Would you consider that still movement or not? And it's not standstill. Or are you saying that it's not really meaningful movement, purposeful movements, and that's not going to be perfusing anything, and so we'll equate that to standstill? That makes it trickier as well. If I'm seeing no movement earlier on, that I don't think that changes what I'm doing. But if this is 20, 30 minutes in and I'm still seeing no movement, then that leads me more towards, okay, I think we've done quite a bit of resuscitative efforts here and we're still seeing no movement at this time. And for me, that's going to be generally no ventricular movement. And if I'm also seeing that the contrast where things are just slowing down and there's just no perfusion going on, okay, I think it's safe to say that the outcomes are not going to be great at this time. However, in saying that, we also know we can't prognosticate off the ultrasound data either.
Definitely. It's a good topic.
A lot.
25 minutes in, I think we've all agreed that time off the chest is bad.
Yes.
And there's positives here and there's negatives here. And yet I know my next code, I'm going to be using ultrasound.
Yeah.
Faith, you said this is a tool that we don't want to take away. It's at this particular point, I am not comfortable running a code without at least one check for reversible causes on the ultrasound. So if we're going to be doing this, how could we do this in a way that does not cause patient harm? And that takes us into this last article, which is the Gottlieb 2023 article. And it's in an emergency medicine journal. And it talks about some practical tips for ultrasound in cardiac arrest. And I'm going to go through both these and get your opinion and see if there's anything you'd add or subtract for this. So he talks about have the most experienced person perform the scan. And right off the bat, I'm not sure how I feel about that, because we said earlier that if you're running the code and doing a scan, then that is associated with increased time on chest and perhaps increased time for the pulse check. And so I know if I'm running a code, I may not be the person that does the cardiac exam because I don't want to step away. So right off the bat, I understand his suggestion and I'm not sure I 100% agree with it. And then next we have someone besides the team leader perform the scan, perform non-cardiac applications such as looking for a DVT while compressions are ongoing, place the transducer on the chest to identify the optimal window prior to pausing compressions. Gary, that sounds like it's right in line with your usual practice. Yeah. Focus on recording the clip, then analyze after compressions have resumed. And have a designated timer count down from 10 seconds, which again, that makes a lot of sense to me. What would you guys add or subtract from that list?
I think that, like you said, I mean, it's a lot of these are with caveats, right? So the most experienced person does the exam during the code. Maybe rewording that to someone that has done this before or has some form of systematic approach to it. This is not the place to be learning this. And so then we can go to the importance of doing what you guys do, the CASA exam, and some more formalized, like systematic approaches to getting the windows and what you're looking for first, second, third. This goes back and says like, we need to be training people how to do POCUS in emergent situations. So using simulation, having them do this on a mannequin, do this on under a time crunch in less acute patients before they actually implement this in a code. So not the first time you're doing this in the code, but maybe not necessarily the most experienced person in the room, like Lissa when she runs her codes. I'm looking at the other things here and see what other comments I had. Yeah, and just practice. We have to practice this. Lissa had mentioned before we started about having someone count down, having that, if that's an intrinsic function of your echo machine, which that's pretty cool. I didn't know some of those echo machines will beep. I have a low-key one, but yeah, it's just about practice and working as a team and making sure that we do this in a systematic way like we do ACLS and other resuscitation.
Yeah. And it's going to vary. Your practice is obviously going to vary depending on location. How I practice at the main campus, when I have more resources, I also have a senior resident with me potentially as well, versus when I'm at my community shop, when I have a very rinky-dink ultrasound and I'm the one running the code, doing the ultrasound as well. In those cases, more often, if I'm really just the only person running the code, I'm more likely the ultrasound isn't used as often readily right away because I'm getting everything else situated because I'm running the code at that time. And then I'll work in the ultrasound maybe after a couple of cycles. That way I've got my rhythm into my whole process, and then I'll have to probe on because it is difficult to manage the ultrasound in the community and run the code at the same time. And if they're coming in, my first few checks are just to make sure like what rhythm are we in anyway, just to see if these are shockable or not. And if they're not shockable, then I'm also working in the ultrasound thereafter. And once I'm seeing what kind of pattern we're getting into, then to look for the other reversible causes. But generally, the ultrasound doesn't come out right away for me. when I'm at the main campus and I'm having my resident, like a third-year resident, really take the leadership role and help run the code as well, then that ultrasound comes out a lot sooner because I've got delegation there as well.
Yeah, and that takes us into the FAST protocol, which you guys have been side referencing
Yeah.
throughout our conversation. So this is from a paper. This is also by Kleinberg and all. So this is the same folks that did the paper we started this off with, talking about increased pulse length. And Gary, like you said, what they found is when they introduced a standardized protocol, that decreased the amount of time on chest and it decreased those elongated pulse checks. And so what the CASA protocol is, it's 3 separate checks. So instead of looking for everything at once, you place the probe on, you look for cardiac tamponade, you take it off, you do 2 minutes of ACLS. And then on our second check, we look for right heart strain, 2 more minutes of ACLS. And then the third check, you look for cardiac activity. And they stress in their paper that you want to place the probe on the chest before stopping CPR, having separate people perform POCUS and run the code, and then again, having someone count down from 10. And I liked this. I like anything that's protocolized when it comes to ACLS and resuscitation. I think it's very helpful. It helps you not forget things, and it helps keep everything organized. I think we've all read the checklist manifesto by Tulga Wanda. I feel like it's required reading at this point, but I do like a good checklist during resuscitations. Gary, have you used this protocol?
Yes and no. Intuitively, this is what I'm doing. It's never really been protocolized for me per se. I think I've been doing CASA without realizing that I was doing CASA, if that makes sense, because that's just what I'm checking for right away. But it's not necessarily the standard.
Yeah,
Like
that makes a lot of sense.
that's
And
not how
Faith,
we've standardized it.
Yeah. I think I honestly, because
yeah,
I am not exposed to the POCUS stuff. I'm more of a formal echocardiographer. And so I think I'm going to start teaching my new fellows and some of my residents this, because I too like standardized checklists. It frees the cognitive space to think about the whole patient. And if I teach them like, hey, I'm going to look at this first, pause, this and this, that I know what I'm going to do. I know what I'm looking for. I don't have to like really flub under in the chest to look for wall motion. No, I know I'm looking for tamponade, and then I'm looking for the RV. I like that. I like that system approach, and I think it will do well when I start to introduce this to some of my trainees.
I think it makes a lot of sense. And similar to Gary, I don't know that I had sat down and thought, I'm going to do this protocol, but this is essentially what I do.
Yeah.
I think the only thing that's a little different is looking to me, it looks like they do all 3 of these checks in order. And I don't do my standstill exam until at least 20 minutes into the code. So this ends up being more like 1 or 2 checks to answer my questions, and then a 15-minute break. And then maybe I go back and do a third. But I think this makes a lot of sense and seems like a reasonable approach.
And there are some caveats about this as well, particularly when it's checking for pneumothorax, that would depend on what kind of airway we have secured as well. If we have this airway secured and you're also not seeing lung sliding on the left side, well, did you have a possible main stem intubation during your whole code? And now you're going to pop a chest that doesn't have a pneumothorax, because if you either main stemmed or just on the left side or right side only, you're not going to see lung sliding during those cases as well. So that's just the caveat with that as well. Just when if you're concerned that this was a tension pneumo that precipitated all this as well.
Yes. And like I said, of course, my primary experience has been trauma codes. So we're
Yeah.
not looking for lung sliding, because at the
Yeah.
time they were arrested, like they better have bilateral thing with thoracostomies already,
Yeah.
or we're too slow. All right. It's been a really great conversation. What other thoughts do you guys have? This is such a great topic and a great conversation. But what are your big takeaways or other thoughts about ultrasound and cardiac arrest?
So we did talk about on the chest or doing subxiphoids and everything else too, but there's also a discussion to be had about having a probe on the femoral artery or elsewhere as well, or on the carotids, and looking for pulse checks that way as well, which is it's a whole other conversation to have as well. Not getting fancy and doing Doppler assessments on that during the code, but at least just looking for color change and seeing if there's actual pulsatility as that, because sometimes it can be hard just to feel the pulse depending on body habits as well. But if you get an ultrasound that's showing pulsatility, that might lead you differently, because you got some level of return there that you just weren't able to pick up on otherwise.
Yeah. I think from this, I trained in a time where we didn't have a lot of POCUS. I got out of fellowship in 2017. And so we were just starting to use bedside ultrasound and handheld probes to do little assessments of cardiac function and fluid status. And so the majority of my formative code and ACLS training was in the absence of point of care ultrasound. And so I think when going back and with your guys' guidance, looking through some of this and thinking about our clinical practice, we in medicine need to start teaching this a little bit more. And with all of the new easily accessible technology, I think what I've taken away is as the subject matter expert in the room, most times I need to actually teach them how to approach this and to do this with a standardized, organized assessment method. And I need to start teaching this because I think the ER does a lot better job in incorporating this into their curriculum than we do in medicine. And especially in the military, we need to be able to practice in all locations and in all scenarios. And I need to teach my trainees how to resuscitate people and how to use the tools available.
Thanks, Faith. Definitely having a protocol helps. I know I didn't used to teach this very deliberately because it didn't seem like it was different. I was like, you're just going to look, this is part of an echo, you do this. And I did slowly realize over several years that this is not the same. This is a very different exam. It appears superficially similar, but it's definitely got its own complexities to it. But thank you guys so much. This was such a great conversation. For our listeners, if you are a member of the emergency ultrasound section, CME is available for this episode through the EAEM website. And for everyone else, tune in next time. We're going to be talking about valvular pathology, which I'm very excited about.
Ooh.
Yeah, thank you, everyone.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.